Okay, so thanks for the opportunity to present at your ground rounds. As I said, I'm Hosam Serag from the UK doing a fellowship here, Uro-Oncology. So I've taken out the first line, which is the debate, because it's not really a debate. I'm not going to do it myself. I'm trying to stay here impartial and just going through the evidence, and then you can decide whether that argument is valid or not. So there is no doubt that radical cystectomy is a challenging operation. It's associated with significant morbidity. It requires a long learning curve and experience. It's an expensive and costly procedure, whatever way you do it, and that applies to bladder cancer overall. It's an essential part in the treatment of muscle-invasive bladder cancer and sometimes non-muscle invasive bladder cancers. Then there is the issue of training, and among most training programs, even across the world, there was a question about how many is the resident at the end of training has completed, and how can he do it independently straight away after finishing training. He or she. So in terms of the approach, okay, so this graph here shows that there is some growth in minimally invasive radical cystectomy over the years. So this is data from the National Cancer Database, and it shows that it's gone slow. It is slowly growing. Up to 40% of cystectomies in the US in 2013 were done minimally invasive, but you don't see that slow grow in robotic prostate perhaps, and in robotic partial nephrectomy. It's probably more growing than that. And at that time, there was 90% of process done robotically. So there must be a reason why this is not really growing very quickly as other operations in urology. So generally, when we're talking about this topic, the comparison points fall between discussing the morbidity, the complications, difference in the oncological outcomes, a bit about the learning curve, and the costs. So these will be the main points that we are going to be discussing through reviewing the evidence. So let's start with this first systematic review that was published in 2015. So they looked at 19 studies, 2 randomized controlled trials, 10 prospective, 7 retrospective. There was nearly 780 robotic cases and nearly almost 1,000 open cystectomies. All urinary diversions were extracorporeal. So 16 report extracorporeal, 3 were unclear. They didn't really specify in the paper, but I'm pretty sure that they were extracorporeal as well. There were similar numbers of new bladders were constructed between the 2 groups, so that will that is significant in terms of when they comment on the OR time. What this shows. So first thing, blood loss. So 10 studies, nearly 1,100 or 1,200 patients. It showed significantly lower blood loss in the robotic cystectomy. When they did a further subgroup analysis for surgeons who did more than 50 cases, that benefit was even more evident. This is a forest plot on the right. What about perioperative transfusion? So 7 studies reported on 820 patients, and they showed significantly lower blood transfusion in the robotic cystectomy group, and that was statistically significant. Pooled data from 3 studies, they pooled about 240 patients, and the intraoperative transfusion as well was lower. What about length of stay? So data from 10 studies, more than 1,200 patients, and that showed length of stay is significantly shorter in robotic cystectomy. The story is looking very good so far, but operative time, 9 studies, more than 1,000 patients, significantly longer OR time. There's another study which I will show the mean and median OR times, which will be a bit surprise. Positive surgical margins, there is no difference. This was data from 9 studies, 918 patients. The positive surgical margin for the robotic was 5.5% and 8.8% for the open group. About lymph node yield. So 13 studies, 1,500 patients. Surprisingly, more lymph node yield in robotic assisted radical cystectomy. The 2 randomized controlled trials didn't show any difference. That's a bit, again, surprising figure, but there was no standardization of what extent of lymph node dissection is performed. It's also known that to go above the bifurcation of IX robotically is a bit more challenging. So how did this figure come? In terms of overall complications, 5 studies reported on the 30-day complication rate with more than nearly 600 patients, and there was lower complication rate in the robotic group overall. But for grade 1, 2, and 3 complications, there was no difference. For grade 4 complications, there was a lower complication rate in the robotic group. Now, the 5 studies reported on the 90-day mortality, complication rate with 760 patients, and that had a lower complication rate in the robotic group. Again, there was no significant difference in grade 1 and 2, but for grade 3 and 4, the complications were generally lower in robotic group. In terms of mortality, within 30 and 90 days, there was no difference. Again, this is the force plots showing the top one is the 30-day complication rate, and the bottom force plot is the 90 days. Okay, so what about readmissions? There was that paper by Hosam et al. Published in Urology in 2017, and that these were patients examined from the claims data from a national US health insurer. There was nearly 930 patients, 84% of them were open, only 16% were robotic. Length of stay for robotic versus open, 7 days versus 8, but that was statistically significant for robotic. There was no difference in the 30-day readmission rate, 24% versus 29%, 29% for the robotic. And there was no difference in the length of stay, the reason for, or the timing of the readmission. Look at this graph. That the dark gray is the open cystectomy, and the light gray is the robotic cystectomy. And for all causes of readmission, they were pretty much equal. There was no big difference. But statistically, it wasn't. And here, in terms of readmissions and the length of stay, so that shows the time of admission, and you can see that the top line is the robotic group, and the bottom line is the open cystectomy. And you can see that the 2 lines really almost match, so there is no difference again. What about this? Ureteral strictures. Nobody talks much about this, but this is a paper just published 2 months ago in Urology, and robotic assisted radical cystectomy has a higher rate of ureteral strictures diagnosis and interventions. So 6 months, that's 12% compared to 7% for the open group, and at 12 months, that is 15% compared to 9.5% for the open group. And these figures seem to be a bit higher than the figures that we know from all the open series or all the data. So this is, I think that is, no, I'll have to go back. I can't remember. Yeah, there is a good explanation, and perhaps you might be you don't have any tactile feedback. You might be pulling more. You might be dissecting more, coming closer to the ureter and devascularizing it more. And I think historically I heard that the left side ureter strictures are a lot higher. That's the side that immobilize more.
That was the difference in tech. Now everybody might be understand. Even in the open area, it's changed.
I don't think so, but we'll. And that will come in another trial. We'll have probably similar figures. In terms of there was lack of good quality trials in terms of comparing robotic cystectomy and open radical cystectomy. All of the previous, that systematic review was mainly on retrospective studies. So the Razor trial was a trial, randomized, open label, non-inferiority trial, phase 3 done in 15 medical centers across the US. They incorporated patients from T1 to T4. N1 were included, but M0 bladder cancers. Also, they included CIS or refractory CIS. Patients with previous open abdominal or pelvic surgery who had any pre-existing health conditions that would say pneumoperitoneum were excluded. So here, that again, it's a bit of cherry pecking for the robotic group. Like patients would still have a cystectomy, but they were excluded. All robotic cases were extracorporeal divergent. They recruited or analyzed eventually 300 patients, equally randomized between robotic and open. The primary endpoint of this trial was the 2-year progression-free survival. We're starting to talk here about focusing more on the oncological outcomes. That was published in the Lancet in 2018. The secondary endpoints were the blood loss, blood transfusion, surgical margin status, the number of lymph nodes, OR time, length of stay, 90-day complication, quality of life outcomes at 3 and 6 months, also some blood work and intraoperative fluid requirements. The results, in summary, showed that the 2-year progression-free survival, there was not inferiority of the robotic assisted radical cystectomy. So 2 years for robotic group was 72% compared to 71.6%, and these were very similar. Estimated blood loss, again, there was evidence that it was significantly lower in robotic assisted radical cystectomy, with 300 mils for the robotic arm and 700 mils for the open arm. Blood transfusions, again, were subsequently lower in the robotic group at 24% for the robotic and 45% for the open. And again, these figures seem to be extremely high, and matches what we see in real life practice. So 45% of open systems. Length of stay significantly lower for the robotic group at 5 days compared to 6 days. The OR time was significantly longer in robotic cystectomy. So robotic cystectomy median OR time 428 minutes, nearly 7 hours. And for the open group, that was 360 minutes, that's nearly 6 hours. Again, that figure, that seems to be, I struggle to remember the last cystectomy that I stayed more than 5 hours. Usually it's under 4. I think that's the skin like skin to skin times. So all that, that was all extracorporeal. all the that is coming later. That's don't steal my thunder. So the lymph node yield for the robotic group, again, that was equivalent, 23 lymph nodes in average compared to 25 for open. Post-surgical margins, again, there was no difference, 6% robotic versus 5% open, and the conversion from robotic to open was in 3%. They used that figure to say that the surgeons who were doing the robotic were quite experienced, and they had a low conversion rate. Again, these are the tables from the study, again showing the same figures in terms of blood loss, the length of stay, OR time, and all the figures that I've put in the figures. This is the perioperative complications. I couldn't see that they've done a statistical analysis, but I've highlighted the common ones that we commonly see. In terms of anastomotic bowel leaks, there was none in the open group, and there was about 2% in the robotic cystectomy. In terms of perioperative ileus, 20% for the open, 22% robotically. Bowel obstruction, again 3% for both. UTIs, so they were a bit higher in robotic. I couldn't see an explanation why. About 35%. That was 26% open. Uterine strictures here. So that's they put that in that tiny table there. So 7% for the open and 9% for the robotic. And that is matching what I showed in the previous slide. That 7% in open, saying that's a bit high. It's a bit lower, 9% compared to the other study that I put earlier. In terms of anastomotic leakage, 3% for the open and 2%, so they were pretty much similar. And thromboembolic events, it was 8% for the open and 5% for robotics. And that's another table for the lymph node and post-surgical margins. Just that. So you can see here that when they did the Kaplan-Meier curves at 36 months, so that's more than 2 years, you see that the two lines, the red line is the open and the black line is the robotic, and you can see that both lines are pretty much identical in terms of progression survival. There was the study was designed to show non-inferiority of robotic cystectomy. And they actually used a very generous margin of 15% to do the statistical analysis. And they got that there is no reason for that figure apart from they extracted that figure from the studies looking at laparoscopic colorectal surgery, open versus laparoscopic. In summary, what the Razor trial says is what are the benefits of robotic cystectomy? In general, less blood loss, lower transfusion rates, and lower median length of stay in the hospital. There was no difference in terms of major complications, more than grade 3. No difference in lymph node yield, no difference in post-surgical margins. Surprisingly as well, no difference in the quality of life patient-reported outcomes. The main negative they pointed out is the duration of surgery. They actually did a further analysis of the study at 3 years' time, and they were trying to report on the predictors of the recurrence, the progression-free and overall survival for an open versus robotic radical cystectomy. So the progression-free at 36 months was actually 68% compared to 65%. Again, no difference. Overall survival at 3 months, 74%, nearly for robotic, and 68.5% open. And they concluded that there was no significant difference in the cumulative incidence rates of recurrence. But what are the predictors of recurrence and progression-free survival? It was the age, more than 70 years, performance status, major complications, the stage, and the positive margins were significant predictors of recurrence, progression-free survival, and overall survival. But the surgical approach was not a predictor of any outcome. It was another trial. It was before the Razor trial. That was an MSKCC. So I put it briefly here because I think it was from Razor trial probably overrides that. That was a prospective randomized trial completed between 2010 and 2013 with nearly 120 patients randomized between robotic and open radical cystectomies nearly equally. Again, everything was all extracorporeal divergence, and the primary endpoint was the 90-day mortality. In summary, for this study, there was increased OR time, lower blood loss, less wound complications for robotics. There was increased cost, and that was nearly $4,000 for a neobladder and 1,700 for an ileal conduit. We couldn't do a cost analysis in that Razor trial because it was multi-centers, and they couldn't really do a uniform statistical analysis for that. There was no difference from the MSK trial in terms of complications at 90 days, whether the high or low grade complication, length of stay, no difference in surgical margins, no difference in lymph node yield, and the quality of life as well was the same at 3 and 6 months. One caveat to this study, the open arm was done by surgeons who were experienced in doing open surgery, and the robotic group was done by somebody who's just been appointed and is just starting to do the cystectomy. So this is just something to say. No, I didn't. No, not in this one. Many.
That was a rare complication.
There was no breakdown, but I guess it's a mix of both time and probably maybe see that disposables same. Could it be the length of stay and OR time? When we're talking about robotic and open cystectomies, why is there a concern about the oncological outcomes? What is the previous thoughts about that? There was increased incidence of altered patterns of recurrence, such as peritoneal carcinomatosis, use of pneumoperitoneum, the loss of tactile feedback. You can't feel where it's hard and where it's soft, and so you might end up cutting into a specimen, doing it robotically, and the excessive handling of the specimen with possible dissemination of tumor cells in the peritoneum. But that is the concern, but with no evidence. So if we look here at the evidence for that, this was a study from the International Robotic Cystectomy Consortium. This is a 10-year follow-up. That was a retrospective review. 26 institutions over 13 countries were involved. They extracted the robotic cystectomies that were done more than 10 years ago, and they found 446 patients. Extracorporeal diversion was done in 6%. So this is the first presentation that I will include some of the intracorporeal diversions. Blood loss again was quite low, 400 mils. Blood transfusion 7%. Median length of stay 9 days. ICU stay 1 day, and OR time 390, nearly 400 minutes. There's no comparison here. This is all robotic. Post-operative complication in 51%, 27% within 30 days, 9% within 30 to 90 days after robotic cystectomies, and the high-grade complication rate of at 23%. Perioperative 90-day mortality was 4%. 43% of the patients were T3 or higher. 24% had node positive disease. The lymph node yield was about 14 lymph nodes, and positive surgical margin 7%. Relapse occurred in about 35% of the cases. 15% were local in the pelvis, and 29% distant metastasis. That theory about peritoneal carcinomatosis was not really true in this study. There was only 1% and happened in 6 patients out of the 446 patients after 10 years of follow-up. And they have not reported a single port site recurrence in that study after following these patients up for 10 years. Perhaps that's not really true. Look here for the 10-year oncological outcomes. The overall recurrence-free survival was 59%, and the graph number A The red line is T2 disease. The blue line is non-muscle invasive bladder cancer. Green is the T3, and the bottom line is the T4. And as you can expect, with the higher stage of cancer, the recurrence-free survival was getting lower. The top right is, which this doesn't work on the screen. Top right, disease-specific survival was 65% overall. And again, as the disease is more advanced, you get lower disease-specific survival. And the C, or the bottom right, is the overall survival at 35% overall. Break down. So what I found is I tried to compare between a big open series. So on the right side is the USC series by Stein et al., published in 2002. And on the left, you can see the same recurrence-free survival from this paper. And you can see that the lines look pretty much, the graphs look pretty much similar in terms of recurrence-free survival over 10 years. And again, on the far right, this is this series, and on the left, this is the big open series that are published, and with big numbers, somewhere between 500 to 2,700 patients in the open groups. And you can see for all the oncological outcomes that there is no big difference between that retrospective study and these retrospective open series. In conclusion of that study, the robotic assisted radical cystectomy seems to have a 10-year recurrence-free survival, disease-specific survival, and overall survival comparable to those of the open radical cystectomy. Current rates and pattern are also similar. There is no increase in peritoneal carcinomatosis or port site metastasis shown in the study. Logical outcomes, they appear to be mainly driven by the disease aggressiveness rather than by the surgical approach. So what about the learning curve? It's a long learning curve, however way you do it. Transitioning from open to robotic techniques can be difficult. There's little reports on the learning curve of radical cystectomy in general. Is it easier to do a robotic cystectomy now with the prevalence of robotic process, and many people are trained to do a robotic process? They've got access to the pelvis robotically, then they can progress after learning that to robotic cystectomies. In terms of learning curve for open radical cystectomy, there was that paper by Perioperative et al., and they actually put these figures to as a guide for the SUO fellows to as a guide of how many they need to do and what parameters they should be looking at. So number of cases per year, to do at least 10 per year to maintain proficiency. Overall margin status under 10%. To have clear margins in T3 and T4 disease under 15%. Do a standard pelvic lymph node dissection at least in 80% of your cases. And to do a lymph node yield of at least 10 to 14. What about the robotic cystectomy learning curve? So this is for, again, study extracted from results from the International Robotic Cystectomy Consortium that was published in the European Urology in 2010. They say that 21 patients are required to achieve an operative time under 6.5 hours. And then in terms of lymph node yield, to get, you need to do 8 to, in average, to reach 12 lymph nodes. You need to do 20 to reach an average or median lymph node yield of 16, and you need to do 30 robotic cystectomies to reach an average or median lymph node of 20. Your positive surgical margin rates goes under 5% when were achieved after you've done 30 patients. And for the patients with pathological stage higher than T2, positive surgical margin rates of less than under 15% were achieved after 24 patients. This is the number of cases that you're looking at. saying you don't need to do more cases to get a higher lymph node count. Okay, so the Pasadena Consensus Panel, a group of experts, they sat together to decide what is the best practice in robotic radical cystectomy and within reconstruction. So they recommended, again, for the first 20 to 30 cases, to do it supervised by an experienced mentor, to keep your operative time under 7 hours, to keep your blood loss under 400 mils, do a complete lymphadenectomy, get a margin status under positive surgical margin of 7%, and be careful if you're operating on a bulky tumor or these patients, previous radiotherapy, surgery, or adhesions. And you only, in the beginning of your learning curve, you only do reconstructions. And then who's the expert as defined by those experts? A very experienced surgeon doing robotic cystectomy who's done more than 100 cases. They have few contraindications to go ahead and do the surgery. They can perform cystectomy that Ule conduit in under 4 hours, or a neobladder in under 5. Keep the blood loss below 300. Complete a full lymphadenectomy. They use neobladder or continent reconstruction in 25 to 50% of the cases, obviously depending on the case mix. Aim for a lower grade of clavodium dildo grade 3 and 5 of under 30%. And aim for a length of stay of 5 to 10 days. So, what about cost? This is here. I think your head might turn the other way. Sounded marvelous so far. Not really bad. Fixed OR costs. So the costs are divided into fixed OR costs, with paid for our course, robotic instruments, which was $2,300 per case. Cost of maintaining your robot, then the variable OR cost, anesthesia and OR personnel time, and obviously as the OR time increases, you can imagine that these costs are going to go higher. And in terms of saving that you can do, hospital costs like hospital cost per day, $940 per day, and blood transfusion cost per unit of nearly $270. Okay. They are about 3-4 years old. But that is that $2,300 Canadian dollars. That is that's probably more expensive here. That's US dollars. And actually, it's a bit surprising because I think in the UK that is again £1,000, which is like more, but depends on how much they sell it in each. It's very difficult to put your finger exactly on the course. It just goes into a massive system. So again, this paper by Uro-Oncology, and I've extracted the figures of the cost from here. So this is C-post data. This study was in, again, I think 2 or 3 years ago. So the inpatient stay for a robotic cystectomy was roughly $3,000 more expensive than an open cystectomy, and that was $4,000 robotic compared to 21. Named more expensive to do robotically at 30 days, and it remained more expensive as well at 90 days. So even if you really shown that there is no lower readmission or complication, but even if you had any improvement on your robotic, that shows that it's still more expensive, no doubt about this. So where's the catching point here? I put this figure and I highlighted here. This is from the systematic review. 16 were extracorporeal and only 3 were unclear. What's the point of spending all that extra time and money and then you eventually open up again to do the reversion? It seems counterproductive to me. Perhaps if you can show that you can do the whole thing intracorporeal with specification, that you might start to think about it. The incisions I've seen for cystectomy, especially here, I don't think that is much different to what you do for reversion. Still, it's a fairly small incision. So what's the point? So this is not published yet, but this is our ongoing trial, so watch out for this IROC trial. This is a prospective randomized control trial, randomizing patients from multiple high-volume centers in the UK in a one-to-one fashion, either open or intracorporeal robotic radical cystectomy. Surgeons who are recruiting into the trial have to overcome the previous caveats from previous trials, have to have performed more than 30 radical cystectomies with whatever technique they're going to be used, either open or robotic, and have a 90-day mortality of under 5%. So trying to raise the standard for the type of surgeon who's going to be involved in this trial. Also, the surgical centers working as part of the IROC trial will withdraw robotic cystectomy from the standard of care. So no patient will be allowed to have a robotic cystectomy unless they are enrolled within the trial. Otherwise, the standard of care would remain to be open cystectomy. Only centers performing more than 35 radical cystectomies per year who had an enhanced recovery program in place were allowed to join. Part of the wonderful length of stay in robotic group is, in theory, hospitals or places that were doing robotic cystectomy, they were adopting a very aggressive enhanced recovery protocol, and that was not really the same case for the open cystectomies. So perhaps that is why they were showing some improvement in that parameter, particularly length of stay. So they're expecting to recruit a sample size of about 320 patients, and they set up a primary outcome in the trial of the days alive and out of the hospital at 90 days. Secondary endpoints are the functional recovery using some activity trackers, share to stand test, and health-related quality of life questionnaires. They will also look at morbidity, complications, and readmissions, the cost effectiveness and the unit cost, and they are also looking at surgeon fatigue. This, I think, will be probably out sometime in 2020, perhaps 2021, depending on when we finish recruiting. So, yeah, 320 patients, so similar to the Razor trial. That's the yeah, but it's going to be this will be the first one that will look at the intracorporeal diversion. So that will be trying to do a purely robotic procedure. Because all the previous, all what we've discussed, they still open up to do a diversion. If you want to use the benefit of a less blood transfusion for that particular, that's the clear benefit from doing it robotically, and then you open up to do diversion, fine, but that comes at a big cost. And I think this is probably why robotic radical cystectomy is not really growing rapidly and quickly as other like robotic prostates or other procedures. Um, Um, yeah. So the trigger for that trial was actually in the UK, NHS was withdrawing funding for it. So they were going to take away the funding unless somebody shows that there is a clear benefit. They were basically saying you're not really showing. You might be showing it's not worse, but you're not showing it's better. So why you and if you incorporate the cost into this, it's very expensive and there's no benefit. Hospital stay 1 day is not in some studies and maybe not different in others or equivalent, then what's the point? What are you gaining by doing the robotic cystectomy, spending all that money? I think that applies to a similar publicly funded system like here in Canada. I think that was the trigger. The surgeons are trying to justify keep doing robotic cystectomy by saying, oh, if you do it intracorporeal, then it might improve in outcomes. Yeah. So I think the main centers is UCL in London, John Kelly, Bristol, where Anson House is working. I think Cato is in. So this is the first time. This is the first study that they say they will report on that. As long as they haven't published this yet, I don't know really how are they going to quantify certain fatigue. And this is going to be very big, and I don't think we will get the reading on that. How are you going to justify that if somebody unfit like me gets that and is feeling knackered at the end of the operation and somebody super fit? How are you going to quantify that? I don't really know unless you're going to put him on put a halter on the surgeon and he's operating something. Yeah. So in summary, overall, finally, this is probably the message, is robotic cystectomy is comparable in selected cases, again, not in the complicated ones. So the scoping remains the standard, the gold standard. They are comparable in terms of surgical margin, complication recurrence rates, and in terms of the short-term quality of life measures. The main advantage is one is the reduced estimated blood loss. This is the clear benefit for robotic cystectomy, and probably to a lesser extent the recovery and the length of stay. The big negatives is the OR time, the learning curve, and the cost. So thanks for Dr. So for seeing this. Thank you. In the signing room to try to improve the structure's rates and afterwards by
we're not gonna do it because of that, but it will be further.
And I think we're starting to see physically in the market cheaper robots. So the CRM robot is off.
Has one.
Yeah.
So online.
So
Is anybody in Canada doing?
Yes, it hasn't done. So everything forward. So here has done some here, but there have been many cases in Canada where they no. And we still have US.
But in Canada, it's working more. Modern center.
Being robotic.
Not because you Canada. I realize that was before. That we should be
and also the complexity of the new bladder that you can do intracorporeally is actually that you have to make it more simple. You're not doing formal W, and so that is another bit. You're kind of downgrading the type of the new bladder rather than advancing it. You can't do the exact new bladder you're doing open robotically. Yeah, that's fine.
I was at the BT Cancer Summit's Quality Surgical Initiative retreat one Saturday, or 2 Saturdays ago. It's interesting that colorectal surgery markers of quality of the hospital colorectal surgery and laparoscopically. They have actually hard survival endpoints because of the fact that laparoscopic colorectal surgery is associated with quicker admin and therapy times, which refers to their overall outcome. And I think that one of the weaknesses in all of these studies, in the Razor study and this future IROC study, that the endpoints are so weak and you survive like 9 days and you're not going to have very many
Much
information.
difference, exactly. So,
And why don't we look at harder endpoints? It's going to take longer to look at, but it's going to be much harder than costly. You will see his outcomes. Even time for average therapy or just overall survival. Why don't we use that? And is that difficult in numbers? That small? And if so, maybe we can just
To look for overall survival, if you want to, you probably need funding for these trials to keep looking at these patients for 10 years or something. It's done retrospectively.
I'm not looking for 10 years. In 5 years.
5 years.
I'm not sure why is there resistance to look at hard endpoints? And if you do use hard endpoints, then I think it's clear that it's not going to see differences. Yeah, I think it really does. Complications. Very. When it comes to philosophical question, no, maybe we're saying why are we having that? Because that's why it's functional. How well you
They've extracted that this the progression free 3 years from the Razor trial, so that endpoint that we're talking about that is being done 3 years down the line here, and it's showing that robotic is not inferior to open. That in terms of the oncological outcome.
no one talking about that.
No.
I think the other comment on the first half is when you talk about all the retrospective lower stage disease, senior patient, public patient. So be careful. Overselling too much.
Yeah, choose.
Yeah.